Thank you so much. Yes, as she said, this is quite a turnout. Thanks a lot for coming. I guess the D word has a lot of people scared, dementia. So we're going to get used to saying it because there are things about it that are scary and there are things about it that are not. And as cheesy as this might sound, my motto has always been, don't be scared. Anybody know how to finish that?
Be prepared.
Be prepared, yes, good. So, which is exactly why hopefully you're here. And I'm also hoping I can, help you understand some ways in which you can prepare for something like this if you have to at all. So the main thing is I'd really like to make this an interactive talk, more of a discussion. I'll definitely give you a brief spiel, but the biggest reason is that, the same questions that you have, other people probably also have. The other big reason is that it's 2:30 p.m. in the afternoon, post-lunch, and I think a PowerPoint lights out will put you to sleep, and it's generally associated with nap time. So I would definitely not like that. So talking about dementia first, how many of you know what it is? Just raise your hands. Or you think you know what it is? Sure. Okay. And how many of you are maybe caring for someone close to you with it? Anybody? Maybe? And who's scared they're going to get it? No. Everybody's hands would go up. Okay, so what do you think dementia is? Just shout out some answers. When you think of dementia, what do you think of? What are you scared of?
Deterioration of the brain.
Yes. Yes, declining, deterioration of the brain. What else?
Memory loss.
Pardon? Memory loss.
Forgetfulness.
Forgetfulness. Yes.
I'm at a point right now where I dig up something and then I go to the bathroom or go to another room.
Yeah, so,
And then I go back and I can't find it.
right.
So I think that's one of the early indications.
So all of those things. So dementia is actually, it's a constellation of a few symptoms. One of them is memory issues. Another one is difficulty with maybe social interactions, language processes, / thinking abilities, and sometimes also including psychiatric or psychological kind of symptoms as well. But the main point is that all of those things combined, when they start to cause impairment in your daily life, that's what essentially, it's a catch-all term, dementia. And Alzheimer's is just one type of dementia, the most common type of dementia. But yes, it's a type. So there's a few many other types, but my main concentration is going to be on Alzheimer's, and I'll speak a bit about vascular dementia as well, which I'm sure you guys have also heard that term. Okay, so some basic facts about the prevalence of Alzheimer's. There's about 5 million people currently in the United States who supposedly have Alzheimer's. That's a lot, right? And that equates to maybe about a little over 1 in 10 people who are over 65 or older, and about 1 in 3 of people by the time they're aged 85. And by the time we get to the year 2050, the estimated population of people with Alzheimer's in the U.S. is about 16 million. Right. So who knows the population of New York City?
8 million.
Yes. Yes. As of 2016, it's 8.5 million. So 16 million, it's almost basically another New York City full of people with... Yes, yes. So what does that tell you that one of the greatest risk factors might be for Alzheimer's?
Age.
Yes, aging. Shocker. Okay. And another one is also genetics to some degree. And people with family history of somebody with Alzheimer's, they are at a little bit of a higher risk to get it. And if there's multiple family members, the risk subsequently rises a bit more. Other factors include environmental and lifestyle risk factors. So low education and occupational attainment. So someone who's maybe only completed 5th grade or no schooling at all. or occupationally they haven't really, gotten to other professional degrees, etc. Moderate or severe brain injury at some point in their life. And the biggest one that I really want you guys to take note of, cardiovascular risk factors. Yes. And these are the ones that we control. I mean, as far as I know right now, and tell me if I'm wrong, I don't think we can control aging. Do you guys know of a way? I want to start now if you do.
Step in front of a bus.
That's not controlling aging. That's controlling. Okay, so those are the things, like I said, that we can control, cardiovascular risk factors. So you guys are all probably heard of them. What do you think some of them are? Throw some out there. Yes.
Keeping your cholesterol down, keeping a normal blood pressure, keeping a normal weight.
So she said keeping your cholesterol down,
Exercise.
blood pressure, exercise,
Eating good food.
eating good food. Okay. What else? Stress definitely is one of them.
Learning something new.
Well, so what are the risk factors? Cardiovascular risk factors. First, smoking, huge.
Multiple TIAs.
Yes, part of the vascular. So multiple strokes. Obesity, yes, obesity, sedentary lifestyle. Sitting all day in front of the TV on your couch, and that's that. Sound like anybody? Alcohol, excessive alcohol intake, absolutely. What else? We're missing some big ones. Yes, heart disease.
Diabetes.
Yes, diabetes. And it's not just about I'm on meds for diabetes. It's about controlled diabetes. So that's why those hemoglobin A1Cs that your primary care doctor does matter so much. So does that sound like risk factors for something else? You said it. Heart disease. So if one thing you should definitely understand is what's bad for the heart is bad for the brain. What's good for the heart is good for the brain. That's one kind of easy way to remember some of these things that we can control and modify. Another one is sleep apnea. Have you guys heard of sleep apnea? Yes. Patients come to me saying, oh, I sleep just fine. 7 hours, 10 hours. I even take naps during the day for 3 hours. Yeah, that's not normal. That's not good for you. That's too much sleep, okay? Your body needs 7 to 8, fine. If you want 9, you're tired, have at it. I wish I could get that much sleep. So sleep apnea as well as sleep in itself, proper quality of sleep is very important. Okay, any other things that come to mind?
Infection.
Not quite, but someone had said stress. So along with stress, depression, anxiety, stress. Okay? Okay, so there are actually recent studies that show, the most recent ones, that 3 out of 4 patients who had diagnosed Alzheimer's actually had coexisting vascular dementia. So this is why we say that controlling those things can really make a difference. Okay? So we said aging was the biggest risk factor, correct? Right. So another thing to understand is that, yes, aging is a risk factor. It's the biggest one. However, aging alone does not cause Alzheimer's. Okay? Memory loss that causes impairment of daily functioning is not normal for aging. Some people think, oh, well, I'm 75, I'm 80. No, but there's certain levels of impairment that are not normal for an 85-year-old or an 80-year-old or a 70-year-old. Does that make sense? Yes. Okay. So how do we tell the difference between symptoms or signs that are more Alzheimer versus normal aging? Don't you think that's one of the biggest questions? Mm-hmm. Who wants to know what some of those things are? Yeah, I would think so. Okay. So, yes.
Well, I was going to say, sometimes you leave the apartment and you stop and question if you left the gas on.
Yes.
But there'll be times when you leave the gas on and you leave, but you don't remember that.
Yeah, well, not remembering you left the gas on, yes, that is definitely a huge deal. I would say that that needs to be checked. So in terms of just starting with, there's 10 warning signs, so to speak. This is on the Alzheimer's.org Association as well, and I've also incorporated it as part of this talk. So the first one to start with, memory loss that disrupts daily life. We just said that, right?
Repeat.
Memory loss that disrupts daily life.
Oh.
So it's forgetting maybe things you learned recently, repeating things maybe within the hour, within a few hours, calling the same person over and over. Obviously, the person with Alzheimer's may not realize that they're doing that, and they have to be told. Having to really remind yourself constantly of things you didn't have to before, such as this picture here. I have to put a reminder on my iPhone to remind myself where my landline phone is. Yes, so that's within the own home. So that's to a point where it's more than just normal aging. Also, doing things that you used to do every day and now are having a harder time doing them. Versus sometimes forgetting names, sometimes forgetting appointments, but remembering them later, as you said, right? Remembering within a few minutes, hey, I gotta do this. Or, oh yes, I went into a room, a few minutes later you remember why you went into that room. Okay, but not remembering ever and then not remembering that you didn't remember is where the problem is, right? Okay, I'm gonna get some water. So far, things make sense?
Yes.
Yep.
Good. So the next thing is difficulty planning or solving problems. So essentially, some people can experience changes in their ability to develop and follow a plan or work with numbers. Someone used to be able to do their bills before or manage their credit cards, and they no longer are able to do that or having difficulty doing that to a point where it doesn't just come back to you when it's explained. You can't even understand it when it's re-explained to you. Trouble following a familiar recipe. I'm sure a lot of you guys love to cook, and leaving the stove on and setting the house on fire in exchange for a great recipe, not so sure how that would go. But that's something that you've done for years, that recipe, whatever it may be. And now you all of a sudden do not remember things that you've known for over 50 years. Difficulty concentrating. So tasks that you used to be able to do, let's say, much quicker, process things much quicker. Now you just have a harder time focusing and organizing yourself on how to do those same things. Okay. Number 3, trouble completing familiar tasks. So this ties in a little bit with the other one as well. It entails things like I used to be able to use an iPhone or even my flip phone, and now I'm not quite so sure how to dial out or how to find a stored number, but it's something you've been doing for many, many years. Laundry, chores, dishes, how to organize those steps and remember to do them if you are unable to do that. That's a red flag. Using the microwave, right? I'm sure some doctors are like, well, I don't want to use the stove anymore. Please use the microwave. Well, figuring out how to use that microwave. How do I, warm something for X amount of time? That's another sign that kind of falls under this category. Okay? Number 4, being confused about a time or place or date. We all kind of get, one day off here and there. Sometimes I don't even know what date it is. But not knowing at all or not knowing the year, not knowing where you are when you are living in an apartment for many, many years, and all of a sudden you're kind of getting disoriented, even just a few blocks out. That's something that, again, is a red flag, okay? For those who driving to areas where you've driven for most of your life, the grocery store or shopping, and now you're having a harder time navigating those directions. Sometimes it's also if things that are not happening immediately, you tend to forget, well, I need to A, do them, or I need to be somewhere, okay? Number 5, so changes in vision and depth perception. This is a little bit harder to explain, but the one thing I can explain is that I don't want you, so this is not the vision changes we're talking about that are associated with cataracts or old age or, actual reading and focusing. We're talking about being a little more clumsier, bumping into things here and there, losing some of those motor skills where you used to be able to do that and now you have a harder time doing it. Depth perception, essentially, the staircase is a really good example. Not realizing how high a certain step is or how low a certain step is. And that can lead to falls. And we definitely don't want that, right? Okay. So we're at number 5 out of 10. Any questions about these at least?
Was the physical change you talked about vision and depth perception?
Yes, yes.
Question?
Is it a physical change that I'm referring to a depth perception? Yes. Okay, number 6. Trouble writing or saying words. So oftentimes some of the first symptoms I'll hear is that I just can't find the right word anymore. I, used to be able to sit down and write my thoughts, and I just really can't even organize my thoughts. I can't get my thoughts out. That ties in to actually also, like here, it says, I know what I want to say, I just don't know how to say it. So it's using that ability to use the language that is your primary language. Interestingly enough, for those who are bilingual or trilingual, they tend to go back to their mother tongue. And that because if English is their second language, then they tend to go back to their comfort zone of what their primary language, their mother tongue and primary language was, which is a really interesting a sign for people to know if you have older, parents, grandparents, and also for you yourself to be aware of if you notice yourself doing that. Okay, number 7. This is what I think some people are talking about. Misplacing things frequently. Putting things in wrong places. Like, yes, the dog in a hamburger bun. Or books on the stove. Okay, and then you're looking around thinking you don't know where that, book is. You don't know where the dog is. So, Dad, did Granny put flowers in the loo? Thinking it was a flower pot. Exactly. Putting a phone in the fridge and then looking for it everywhere. Okay? So those are, it doesn't have to be this drastic, but you get the idea, right? It's not just as simple as whereas normal aging would be, like I said earlier, going into a room, okay, I can't find this, I don't know what I came for, and then later on, within minutes, maybe even 20 minutes later, remembering what that was or where you put that thing. And if that happens occasionally, not all the time, okay? All right. Number 8, impaired judgment. So what does that mean? Impaired judgment and poor decision making. So, not realizing that, grooming and hygiene and showering and washing your hair and combing it and going to the parlor, if that's what you used to do, now all of a sudden it's disheveled and you don't know what's going on, okay? You think you showered, but other people around you know you didn't, okay? Right, the other one is poor judgment, which means, aside from that, is telemarketing calls. Not remembering, yes, some people look surprised. Those cruises, all these promotions that telemarketers call about or for, yeah, you give your money away to them. One of my patients found out that his wife was actually, she had really almost emptied their bank account. He had to go and she bought timeshares and booked them for cruises. And so that's when he started realizing something's really going on. And, when someone like that, if she's the one who's been always doing the bills and managing finances, the other spouse can't know. And vice versa. If the husband is the one managing finances generally, and the wife is like, I've never cared about those finances and bills, they get paid. But then your phone bill gets cut off, your electricity gets shut off, and you realize what's going on, okay? Even giving money very effortlessly to strangers, like lots of money, to charities. Oh, I'm so philanthropic. But it's like giving away your life savings, and they're not realizing that they're doing that. Number 9, withdrawing from work or social activities. So this is where there's, one of the areas where there's overlap in terms of, in the beginning stages, patients often start to realize that they can't remember certain things, or they're having a harder time having a conversation because it's not just one word here and there. Just getting their thoughts out is a problem. So they start withdrawing from society, from friends. If they used to have a bridge club, if they used to go to play bingo or just socialize with other people and other friends, But when they start realizing they're really having a hard time conversating and they cannot, it's not the same, and other people may start noticing, they feel embarrassed and they tend to isolate. A component of that is also feeling depressed over it. So social withdrawal is really a big sign. Sometimes people will say, oh yeah, well, I'm 75, I don't need to do all that, I've done it all. Well, you didn't retire that long ago, and you didn't work your whole life to just after 10 years of enjoying retirement, you're going to all of a sudden not do anything else anymore. So those are things to look out for yourself and for your loved ones to look out for. Okay, so the last one is also a pretty big one. Number 10, notable changes in mood or personality. Notable changes in mood or personality. And maybe that's not a change for him, but if someone already used to be that way, it may be exacerbated, it may be worsened. Some people, their whole life they've been a little bit of a grouch. Yeah, at this point it's to the point where it's affecting other people, their grouchiness. And their irritability is through the roof. They have very low frustration tolerance. Any little thing makes them agitated. They lash out. Or they start suspecting that their spouse is cheating on them when there's no reason for them to be suspecting that. Or suspiciousness infidelity-wise, someone stealing from them, even their own family members, whether it's their daughter, their son, their spouse, they start becoming very fearful of those things. Also fear of going to places on their own, but it's not just a normal fear, because some people should not be going anywhere on their own. But this is a fear where it's more unwarranted and it leads to bouts of anxiety or frustration and irritability. And the other thing to note on that point is also if that type of personality change or mood change is not what it used to be. Like with their friends, they used to be very, maybe they're grumpy with their husband, but with their friends, they were really nice. That changes as well. So it's across the board, whether it's at home, whether it's at work, or whether it's during leisure activities, okay? So those are the big 10. And how is that different from mood changes in normal aging? It's because, it could be a sign of something else, and not Alzheimer's or not a type of dementia. It could literally be anything. Mood changes are associated with a lot of things from, medical illnesses, terminal illnesses, grieving, etc. Thyroid issues, you name it. They can do it. Yes, you had a question? Yes? Oh, okay.
I will.
You will, okay. Well, that's good. All right. So just briefly, like I said, this is not supposed to feel like a doctor's appointment. I'm not going to get into too many technicalities. But the pathology that underlies Alzheimer's, just a few sentences about that. What causes it? So it's actually actual neurological damage thought to be caused by plaques and this sticky protein called beta amyloid in our brain. What happens is that protein accumulates, and therefore the nerves need to connect, to communicate, right? They are unable to connect anymore. They have difficulty connecting. So initially it's a little bit, so you notice mild things, and then it gets to a point where it progresses, and really the communication is pretty severe, leading to severe impairment.
So is that plaque building part of the aging process?
That's a good question. Is that plaque building part of the aging process?
Oh, thank you.
That's a great question. So,
Poor eating?
well, so let me just address that one. So there are patients who do have plaque in their brain and will never have an Alzheimer's. Then there's patients who may not and can.
Oh.
So, right. So this is why, science hasn't really gotten its final answer. We're reaching closer and closer in the sense, at least now we know that there's a really high correlation. Before we really thought it was, whether you do or don't, it doesn't matter. It does matter. We do know you're at a higher risk, you're more likely than not. Measurable amounts, moderate to severe amounts of plaque will lead to Alzheimer's. Mild amounts of plaque may or may not. There are studies that show it can and can't. Yes?
Is it true you're not really classified Alzheimer's until death?
Yes. Is it true that you can't say, like, a slam dunk, 150% sure that someone has Alzheimer? Yes, but I'll talk about some of the tests and biomarkers that, you know, are more recent, that at least we can be way more sure than not. Okay? So I'll talk about that. Yes.
Are there certain foods that can help not to get the plaque and the plaque come up the heart and the brain, and what foods can prevent
Right.
plaque for the Alzheimer's?
So are there certain foods that can prevent the plaque from forming in the brain or help lower the load of plaque? Well, so I'm going to go back to the point because I really want to drive this home, and we're going to repeat this over and over, and you're going to repeat it after me when you leave here. What's good for the brain what's good for the heart is good for the brain, right? So when it comes to foods, if vascular risk factors and things that affect the heart can cause heart disease and that affects your brain, right? We said that was another big risk factor. Then those same things, if you change those, so foods that are good for the heart. Recently, the Mediterranean diet, there's been a lot of research on that. So what is the Mediterranean diet? It's not just, Olive oil is one, okay. Fresh fruits and vegetables, but yes, greens, nuts, fish. Pasta is not one of them. Olive oil, legumes, yes. What about red meat? Oh, that hamburger. Lemon? It's not part of the Mediterranean diet, but I understand your point too. I never tell my patients, do not eat this at all.
Veggies and fruit.
Yes, veggies and fruit. So you guys, I mean, is this news to you guys? No, shocker. I mean, fish, yes. So all of those things, you know, whether you have it or don't or whatnot, those things can't hurt you. They can only help you. And it's proven that they definitely are good for the heart, right? And now the research is proving that it's also helpful for the brain. So why wouldn't you do it, right? Other things, let's see, cause-wise, I was just wanting to finish that. So beta amyloid, as I was talking about, the sticky protein, it's normally found in the membranes of nerve cells. And as I was saying, when it clumps together, so big clumps versus small clumps, can often correlate with level of impairment. Often, not always. Yes?
Can you find the amount of plaque with an MRI or a CAT scan?
Yeah, she did not talk to me before this presentation, but that's my next section is tests. So yes, go ahead.
Does keeping the body well-tuned and intact emotion help?
Yes, does keeping the body well-tuned and active help? Yes, and I'm going to elaborate on that towards the end. So in terms of tests, so yes, there's CT, MRI, PET scans, and SPECT scans. MRIs so the AAN guideline, the American Academy of Neurology guidelines, recommends it, and actually it's part of the guideline for anyone who has an objective cognitive decline determined by a clinician, a structural imaging. An MRI is the one that can, give you that at the best at the moment. So the other reason for that is because 5% of patients who do complain of certain cognitive and memory symptoms actually end up having other things, whether it be a tumor, whether it be a hematoma, a brain bleed, or other causes. A study found that 5% can do that. So A, you don't want to miss that. And B, MRIs can also help us, in some patients, see if there's atrophy in the brain, which is shrinkage in the brain that's not normal for age. But I want to make sure you realize this. It is not diagnostic of Alzheimer's. There are patterns in brain MRIs that we know from research studies that show, a study on Alzheimer's patients, this is what we tend to see. But some of those same things are also seen in normal brains. So it's incorrect to say, oh, your MRI shows you have Alzheimer's. Your MRI may suggest that in combination with the clinical symptoms and the diagnostic testing done by your doctor and the progressive course of the illness that you are telling them and your family members. And so all of that together is really what paints that whole clinical picture, not just any one test.
Besides the amyloid, what happened to tau?
I'll get there. So the other thing is that now we have something called amyloid scan. So it's an amyloid PET scan.
Yeah, amyloid.
Right.
Yeah.
And that can measure basically the load of amyloid and plaque in the brain. However, it does it with more certainty than anything else, than other imaging, okay? but it's not covered by insurance. It's about $6,000, and there's only a few reasons that the guidelines, say you should have it done. So the other thing I want to make sure you realize is that this is what I tell my patients. And, it's necessary in certain cases. Like if I'm diagnostically confused, if there's a presentation that's atypical for Alzheimer's, then yes, I would probably say, listen, either I need an amyloid scan, or the other thing is spinal biomarkers. So we take fluid from the spine. It's not as bad as it sounds. You're awake during the procedure. They give you local anesthesia, and we send it off for Alzheimer's biomarkers. So for tau, total tau, p-tau, and amyloid beta, okay? So that also can detect the load of amyloid. Again, it's only something that I recommend to really, if I'm confused, or to complete the clinical picture, or there's something called frontotemporal dementia in a little bit of a younger age onset, like 60s, 50s, that if you're trying to differentiate between that and Alzheimer's or early Alzheimer's, that's where an amyloid PET scan could be helpful, and it would be covered. But 90%, if there's good history and good collateral information from a family member, you bet you a clinician who is trained and is, it's their expertise to diagnose this, they're 90% or more of the time right. Yes?
If both parents have dealt with Alzheimer's, is there anything that the children can be tested for to determine whether they would be candidates for?
Right. So if the question was, if both parents have had Alzheimer's, is there anything in terms of testing that the children can be tested for? Early on. Okay, so that begs the question, were the parents literally diagnosed with Alzheimer's, or the diagnosed with dementia, which could be of vascular type or Alzheimer's type? So if it is Alzheimer's, then yes, there's genetic testing that's available. It's generally not the recommendation. It's more based on the family if they want to know. Why do you think that is?
I don't want to know.
There's no cure.
There's no cure, yeah, right? So you're going to drive yourself crazy with stress and depression and worsen your chances and accelerate the process. So it's generally not recommended unless someone feels strongly about doing it, because we can't do anything about it right now. Does that make sense? Yes.
So, if they're showing signs of Alzheimer's, you're not going to be diagnosed with Alzheimer's, but with dementia?
So, if the question was, if you're showing signs of Alzheimer's, you're not going to be diagnosed with Alzheimer's, but you're going to be diagnosed with dementia. That depends on what kind of signs you're showing, and it depends on really what stages you're probably at. Because in the beginning, things tend to look, and this is why they're often mistaken, as normal aging, unless you really, really know the cardinal signs. And that too doesn't happen until a little bit, into the illness. And again, none of these are like slam dunk, super sensitive, super specific. It's the whole clinical picture together. So early on, it could be called something like mild cognitive impairment. Have you heard that term?
Yeah.
So that's where, exactly as it implies, mild difficulties with memory, thinking, social interactions maybe, but not impairing daily function. That person still is able to handle their bills. They're able to, go to places on their own. They're not getting lost in a subway system that they've, taken the public transit for like 50 years. Yes?
Is that synonymous with early onset?
Is that synonymous with early onset? So I will touch on that briefly. Early onset is a term that we use to describe basically symptoms before the age of 65. That's the cutoff for research purposes. And the research currently indicates that the process probably started maybe in their 30s or 40s. Early onset is the one that is associated with the genetic ApoE4 allele and gene. So I'm not going to get too technically into that, but early onset is different from late onset Alzheimer's. Early onset is the one where the genetic, what am I looking for? The word that I'm looking for, I'm searching for words. Where, the genetic predisposition is really much greater in the children or in their grandchildren. Much, much higher percentage.
Could you finish your lecture and then take questions?
Yeah, I'm sure. Like I said, I want to make it more of a discussion, but don't worry, I'm not leaving anything out, okay? Okay, I'll take one last question and then I'll wrap up, then we'll do just Q&A. Yes, 1 second.
What happens to go back to an aging relationship?
I'm so sorry, I can't hear you.
What if you have Alzheimer's in the family? One is a cousin and one is a non. Now, the cousin is not the opposite child.
So that's a bit of a detailed genetic question. So I'm not trying to, I want to go with more of the more common things that more common aspects of late onset Alzheimer's, because that's essentially what we're discussing. Yes?
Yeah, I read something this morning from Vascular, was a very big fish oil company, and they have these omega-3s, and when it's good for the heart, it's good for the heart and the brain. Can you comment on omega-3s, taking that?
Yes, at the end. Can I comment on omega-3s? And I will. The wrap-up part of just so we only do question and answer is in terms of treatment. So everyone's, or most of you at least, have probably heard of Aricept, donepezil. So Aricept, also known as donepezil, galantamine, rivastigmine, those are some of the common medications FDA approved for Alzheimer's dementia. And for even other types of vascular dementia, they could help. But it's important to note these are not cures. These are medications that can delay the process, perhaps by a year, maybe more in some patients. And in some patients, they may not do much at all. It really is something that you have to discuss with your doctor, risk versus benefit. A lot of them have not too great of a risk, but if you're on like 15, 20 meds and you are in severe stages, the benefit of taking it essentially probably won't be there. It may end up causing more issues than not. Now, taking it on in earlier stages, like I said, in terms of staging and all of that, mild, moderate, severe, and there's other stages that I'm not going to just go into in detail. But taking them early on when you're having symptoms, and if there's an objective cognitive decline on the mini mental status exam is one of the tests that is done. It's a brief, it takes maybe 5 minutes. The doctor can do it. And it's a series of questions out of 30 points. So depending on not just your score, but also your symptoms and report from your family member, they decide whether or not to start it. Another medication is called memantine, also known as Namenda. That is for moderate, it's augmented and added on to donepezil or one of the other acetylcholine esterase inhibitors as an additional medication in moderate stages. It's not approved for mild stages, and essentially it really doesn't tend to help unless you have had intolerability to the other ones for some reason.
Can you explain the lucid aspect of an individual who shows all the signs of Alzheimer's? Is it an area of the brain?
So can I explain right, so essentially these symptoms, if I'm understanding correctly, is there a particular area of the brain that these symptoms perhaps are happening due to? And the main areas of impairment, one of them is, a big one is the hippocampus. So that's in the temporal area of the brain. So that's essentially, those are your memory centers. And it's there on the left and there on the right. Sometimes MRI can show atrophy or shrinkage or volume loss in the hippocampus. Sometimes it can be one side more than the other. And again, as frustrating it is to hear this, it's also frustrating for me to say this. Even though we may see a pattern of hippocampal loss, one side more than the other, in Alzheimer's patients, it's not diagnostic. Some patients may have that and still not have Alzheimer's, okay? And some patients may not have it and still have Alzheimer's, okay? I'm actually wrapped up, so we can ask any questions. And then I want to do an overview of take-home points. Yes?
I wanted to ask you if you would comment on the omega-3 and they say it's good for the brain and good for the heart.
Yeah, so omega-3s, fish oil, omega-3s. My recommendation generally, the literature changes almost every year, 1 year, this is bad for you, the next year, it's amazing. I mean, it puts us in a precarious position, because I don't even know what to recommend then. Coffee, it's so horrible. Well, last year it came out that coffee actually is good antioxidants for you. So then my patients look at me like, you told us to stop drinking coffee. So with omega-3s, I mean, there's really, I think that they can be helpful. Vitamins should be taken consistently. They're not magic pills. If we don't actually have magic prescription pills, we definitely don't have magic vitamins. So anyone who claims that they do, any sort of focus supplements that you see online, or any sort of supplements say for Alzheimer's, get your memory back. No. That's not, those, don't listen to that, okay? Be well educated. Talk to your doctor before you take it. You need to know what you're taking. I think omega-3s can be helpful from the recent research that I've read.
If your B12 is normal,
Yes.
there are some people that are taking pretty large amounts because they hear it's good for Alzheimer's.
You're talking about B12?
B12. A
Right.
quick comment?
Yeah, so yes, B12 is good for you, but like I said, I work well with mottos, if you couldn't tell. Anything that in excess, even if it's something good, anything in excess can't be that great, okay? Because it may have side effects and harmful effects that you don't know about. So yes, low B12 should be corrected because it can cause certain cognitive issues and certain other neurologic things. But that doesn't mean you need to be taking, if your level is like way above normal. I have had other, colleagues and myself where we say, listen, chill on the B12. You don't need injections anymore. You don't need to be taking so much. Same thing applies for vitamin D. Same thing applies for any other supplement and vitamin. Okay, fish oil. I mean, if you take an excess amount of fish oil, it's not going to help you. Okay? Does that answer your question?
Yes, but if you just take it, you have to take it a few times a week. If you don't eat fish, you can take it 2 or 3 times a week.
Take what?
If you're not eating omega-3 fish, if you take the fish oil maybe only 2 or 3 times a week.
No, a fish oil you can take every day. I mean, you should take, there's a daily recommended dosage for it. And you can't begin to eat the amounts of fish that you would actually get in terms of milligrams of fish oil and omega-3s from supplements. So my point was take it consistently if you're going to take certain supplements or vitamins like fish oil. But with the other vitamins like B12 and things like that, it's something, the ones where there's measurable levels, you don't want to be overdoing it.
We need to go on to some other people right now.
Yes.
You were going to tell us the difference between Alzheimer's and normal cognitive,
Yeah, so in terms of some of the things that I mentioned already, like I said, it's the 10 things that we went over. When that's happening all the time, frequently, and in bizarre proportions, that's not normal aging. Normal aging and memory issues don't interfere with daily functioning. They don't cause daily impairment in activities of daily living, like taking meds and remembering to take meds. Patients think they have no issues, and before you know it, either they're taking too many or they're not taking them at all, and they don't even realize it. That is not normal aging. Then that needs to be checked. Things like having issues, as I mentioned, remembering to shower, remembering meals, remembering to use things that you've used for years and not being able to do that all of a sudden. A lot of patients are savvy with the computer. May not be a Mac, but they're no longer able to open a file on their computer.
No, the difference between dementia and Alzheimer's, that's what I meant.
Vascular dementia?
The difference, so the question was what's the difference between dementia and Alzheimer's?
Yeah.
So again, Alzheimer's is a type of dementia. Dementia is a catch-all term for memory issues, thinking issues, and difficulty with social interaction that impairs daily function. You could have different types of dementia. It's still called dementia. But the differences between Alzheimer's and other types of dementia are, as I suggested, since it talks about Alzheimer's, but vascular dementia essentially is when your vascular risk factors are not controlled. So this is part of the, we're asking you, what are the vascular risk factors again? You guys should know them and control them, so tell me. Vascular risk factors, what are they? High blood pressure, cholesterol, diabetes, smoking, obesity, depression, yes, depression, stress, anxiety, not exercising, no social interaction, sleep. Sleep is the garbage truck for your brain. So please let the garbage truck come at night. You guys think you're sleeping so well, and really, if you're up and about or if you're restless, or another key is if you don't have sleep apnea, but you're still tired during the day, your body and brain is not going into a deep sleep. It's not getting the quality of sleep it needs, the stages of sleep. So it's not about quantity, it's about quality, okay? Yeah, so recently there's something that came out maybe 2 days ago, I think, on the inflammatory aspect and potentially immunological aspect of Alzheimer's. And it's still under research, but apparently they found a certain receptor on the immune cells of the brain in the microglia, okay? And that can, basically targeting that receptor in one way or another perhaps can affect the load and the load of amyloid and plaque in the brain, potentially. So again, this is all new, this is all research. There's also clinical trials, the few that are out there that are open and taking patients. They all have their own criteria. One of them is at Burke Rehab Hospital, and another one is right here at Cornell. We're currently doing a medication trial. I believe we're going to be starting to take patients again in the next few months. Yes?
Other than medical treatment,
Mm-hmm.
are you going to address care or analyze support groups of people?
Yes. Sure. There are some great support groups out there for Alzheimer's, and a lot of them are listed on the alzheimers.org website. So if that's one website that I'll definitely have you take home with. Yeah, alzheimer.org, alz.org, I believe. And a lot of the things I talked about today, I got from there because this talk is for the community, and that's exactly for the community, mainly is to how to mitigate certain things, what to expect, how to deal with it if a loved one has Alzheimer's. One thing I want to mention is, if you have a spouse or if you're a parent and your kids should not be taking care, they should not be the main caregiver. A lot of patients are resistant to home care. I'm not saying go to a nursing home, I'm not saying have someone live in your bed with you. I'm just saying a few hours a day for certain people, it's very necessary because caregiver burnout is a huge, huge thing. And oftentimes loved ones think that, oh, well, I love this person. I can't have anybody taking care of them. It's not about having people taking care of them. It's about so you can be exactly that. You're there to love them, support them. You will not be able to do that if you're showering them, dressing them, toileting them. And in those stages, it's essential to have help because caregiver burnout is one of the biggest topics that a lot of Alzheimer's support groups talk about.
Are tremors any indication of a problem going on?
Well, are tremors are any indication of a problem going on? Yes. What kind of problem? It's vast. You may or may not get it, and you do have tremors in certain types of dementias. You may or may not have it in certain types of, Alzheimer's. Some people do, some don't. And so it's not really kind of a symptom of Alzheimer's, so to speak.
Also, do you know why it seems that people with later stages of Alzheimer's seem to revert to cursing a lot?
Right, so why do people in later stages of Alzheimer's revert to cursing a lot? Primarily because, remember, this is one reason, and that's another reason. So some of them don't even realize they're doing it. So essentially, if they used to curse, maybe they used to curse anyway in their whole life, that's their personality. All of a sudden, it's very exaggerated. And, that's definitely something that, it's not that alone, but that's one of the things. Yeah, and in the beginning, it could be out of frustration. A lot of the irritability, the depressive symptoms. At some point, Alzheimer's is called, at later stages, the disease of the caregiver and the loved one, more than of the patient. Because the patient gets to a point where they do not realize they have it, they don't know what you don't know. You forget what you forget. You don't realize you're lashing out at your loved one. You don't even remember 2 seconds later you cursed at them. And oftentimes, family members and other people, they should need to recognize they're not trying to be mean. It's the illness. They don't know. They don't hate you. And trying to reason with an Alzheimer's patient is probably one of the worst things you could do. You will drive yourself crazy, okay? Do not try to reason with them. In fact, reinforce and try to divert. If they want to do something absurd like go for grocery shopping at 2 a.m., clearly we're not going to reinforce that. Divert their attention. Their attention span is very little at that point. You can easily make them, change their mind and move on to other things.
Don't ask too many questions about the person with dementia.
But you don't ask too many questions of a person with dementia. Yeah, probably not a good idea. Yes?
I want you to forget what I said before about misplacing things. I'm a lousy housekeeper. However,
Can you speak louder?
However, I have a doctor, Dr. Leifer, Dana Leifer, across the street, and he's actually terrific too, and I'm sure you know him. But he's got me on a low dosage of Aricept. And when I priced it, I realized it's outrageously expensive, and I started looking at Diagnostic. I've since read 2 different articles on Diagnostic, and both said it does absolutely nothing.
She's saying that she's read 2 recent articles on donepezil, Aricept, that it does absolutely nothing.
Now, if I came here and had someone who further, help me to do further searches, this is just things I've read, 2 different studies, and I'm doing just fine, other than bad housekeeping, which, I always
So let me
find-
address the first part of that. So essentially, as I mentioned before, Aricept, donepezil, it helps some people, in a noticeable way. And when I say noticeable, I don't mean drastic. I just mean certain subtle, noticeable things. And in some people, it really doesn't tend to do anything.
Oh, really?
Yes,
I thought
and
it was just
it's
a
not.
cure.
The reason being is it's not a cure. It's just something that potentially delays the process usually at the most by a year. Patients stay on it, and if you can understand this part of it, if someone is seeming to respond to it, whether it's a placebo effect, whatever it is, as long as they're not having side effects in those stages, and the family member feels that it's helpful, we wouldn't want to take them off of it, right? But at some point, if it's more harmful than beneficial, then we'd want to consider just reducing polypharmacy because of that reason exactly. It's not going to do anything at some point.
Now, you also said something.
One second, let me just go ahead. And yes, somebody else had a question. Yeah.
Could you talk just a little bit about MOCA, the test that our president got?
That guy took? Yes.
Yeah, he got 100% on that.
Am I still on tape? I don't want to talk about it. So can I talk a little bit about the MOCA that our president took? Indeed.
What is MOCA?
MOCA stands for Montreal Cognitive Assessment. And the other common assessment is called the Folstein Mini Mental Status Exam, MMSE. And you can be given usually one or the other. As a specialist, I prefer the Montreal Cognitive Assessment, especially in patients with a higher level of education, because they're already what we call pre-morbid functioning is very high. So the MMSE may not necessarily detect subtle changes. Sometimes the MOCA may not detect subtle changes if it's very, very, if it's very subtle. Excuse me. But at the same time, they're both on a scale of 30, but they have slightly, they have a difference in a little bit in the level of difficulty. And I can't comment about our president on tape, but I will afterwards. And it's one thing to remember about the MOCA or the MMSE is that the score itself does not diagnose anything, okay? Someone could have but they could have an abnormal score, but still be functioning in everyday life. So you're not going to say that that person necessarily has dementia. There's a criteria that's required that a patient has to meet and their symptoms have to meet. So all those things put together give you, the clinical judgment of how strongly you think it's Alzheimer's versus other types of dementia.
Thank you.
You're welcome.
Is there any conflict of treating Alzheimer's at the same time as treating vascular disease, cardiovascular?
Is there any conflict in treating Alzheimer's at the same time as treating cardiovascular disease? In terms of medications?
In terms of treatment?
So with cardiovascular, this actually brings me to the summary point I want you guys to remember. You need to think of cardiovascular risk factors as accelerators, okay? As I said, 3 out of 4 patients with Alzheimer's likely have both. So let's forget about the one we can't do anything about. Let's talk about what we can do something about, and that's the vascular part. And, putting it broadly, there's no contraindication. Maybe certain meds together with other certain meds for cardiovascular disease may have an interaction, but generally no. The so to speak, cure is treating your diabetes, is controlling it. It's treating your CPAP. It's treating the sleep apnea, because there's no pill that can do that for you. It's getting sleep. It's treating the underlying depression. People will tell me, oh yeah, I don't want to take so many meds. Oh, they're for depressed people. Well, if you're depressed, what point is it if you're having memory issues because of the depression and stress? So it's almost like treat all of those things that can be treated, and then what's left over may be something like Alzheimer's. But you'll notice if you have a lot of those risk factors, those big 4 or 5, people have noticed significant differences after using their CPAP consistently. I personally have treated patients who have told me their scores go up. So that's an objective objective measure. And it's not just something that they're feeling or the family member's saying. It actually works. Yeah.
Would statin drugs have any influence on dementia?
I'm sorry?
Statin drugs.
Yeah, I knew that question was coming.
Yeah.
Would statin drugs have any influence on causing dementia, I guess here? So the most recent study that came out said that statins don't cause Alzheimer's and dementia. However, expect things to change. Maybe in the next year they might coming out saying again that they do. At the moment, they're not supposed to. What can happen, though, is that patients on statins for a very long time, and as they get older and older, you can either become more resistant to a drug or you can become more sensitive. So if all of a sudden someone is just atypically presenting to a doctor, I've had at least a few patients who, I'd suggested the primary care try taking them off the statin because it wasn't a clear clinical picture. They were just loopy in ways that they shouldn't be when they're only 70 or 65. And it made a difference in that person. So the risk versus benefit, right? Statins aren't supposed to be doing that, as the most recent study showed. And also, if your cholesterol's through the roof, I'm sorry, that's going to affect your memory way more than any statin medication that we know of, okay? In terms of causing vascular changes. And so if you want to talk about what you can do, you can take your meds for those things. It's not worth having a higher cholesterol, just for that reason alone, that it might do something, if it hasn't already. One second, go ahead, yes.
Namenda, that was brought in going back, and I can only say it from a personal point of view. I ended up having TIAs, and they put me on Coumadin. I had no problems with heart. I have a family history of heart. But the point of it is that, they took me off Namenda because it wasn't doing anything. Now, 25 years later, 20 years later, the suggestion was to put me on Namenda and a combination of a little more prednisone, not prednisone.
Donepezil.
Aricept. So I'm trying it for a month. So my point is, has Namenda changed since like 1994?
Namenda is still Namenda, and it still targets the same receptors, the NMDA, it's called the NMDA receptor.
Yeah.
And no, it hasn't changed. There's just a formulation that's a combination of donepezil and Namenda called Namzaric.
Yeah, Namzaric.
And like I said, each case is individual, so to get into the technicalities of that would not be really do justice, but
yeah.
Yes.
You mentioned CPAC. I don't know what that is. And what's the name of the other?
CPAP. CPAP is a machine that is used for sleep apnea. And sleep apnea is diagnosed after you have a sleep study. So basically what happens is that you don't know this is happening. Seconds, maybe even less, of points at night where your brain is not getting enough oxygen. We call them apneic episodes, lack of oxygen to the brain, those episodes. And if they happen frequently enough at night, your brain is not going to be rested because remember what did I say? Sleep is what? The garbage truck for your brain. So if you're not getting into deep sleep because of those episodes, you're going to need extra oxygen. So CPAP is a machine that helps you get through that proper sleep. And weight gain, and if you're snoring a lot, you can then be diagnosed with obstructive sleep apnea. There's a couple different types, but I'm not going to get into that.
Does a doctor prescribe a CPAP test, and does Medicare cover it?
Does a doctor prescribe a CPAP test, and does Medicare cover it? I believe so, yes. Yes. Sleep apnea is a huge medical condition, yes, from my understanding. And it's the test is normally done by a sleep specialist, pulmonologist or a neurologist or the type. 1 second, yes.
So the medication slows up the process.
Can slow up the process.
And it's not a huge. But the psychological aspect of Alzheimer's, can you treat it with psychotropic?
Yes, the psychological symptoms of Alzheimer's, so whether it's irritability, whether it's lashing out, whether it's anxiety, and why the reason is, whatever the reason may be, the bottom line is generally yes. SSRIs, selective serotonin reuptake inhibitors, your traditional antidepressants generally, like Zoloft, is a great one. And normally most patients respond well to it. Again, I'm not going to generalize it, but usually patients do. And the best part is, patients who are older tend to sometimes actually respond sooner to medications because as you get older, your body actually is more sensitive to drugs, right? Any sort of drugs, medicines, even other kinds of drugs like alcohol. And it could work at lower dosages than what might be required for like somebody who's 40. So it's definitely worth, mentioning to your doctor, and it's worth taking those medicines for it. You'll be happier, and the people around you will be happier. I can't say increase social interaction if you're being grumpy, so.
I think that.
Yes.
I want to thank Dr. Pahlajani. I think this was wonderful. As thorough as one could hope for, I think.
Yes, it's a very, very, it's a huge topic, so I lost sleep trying to figure out how I want to talk about it with you guys. But if anyone has like specific, very specific questions that may not pertain to everybody, I can stick around for a few minutes to answer them.
And could you fill out your evaluation forms?